So welcome back. As people are slowly drifting in, I think we are already 10 minutes late. So I'm joined here by my esteemed colleague, Torsten Denst. We have some very stimulating topics here, which should shake us up a little bit, which is nice. So let me call upon Greg Stone. Greg, you're here? Okay. So Greg has got some revolutionary ideas. Please share them.
Well, great. Well, thank you. It's really a pleasure to be back to the International Coronary Congress, and I'm going to try to open your ideas to some new ways that we've been thinking. I'm an interventional cardiologist, and when we look at coronary disease, we've been frustrated that we're not reducing death and MI, and this is a new way of thinking. And John asked me to talk about a trial we did called PREVENT, which is a new concept for prophylactic PCI of non-flow-limiting lesions, but this applies equally to coronary artery bypass surgery. So I changed the title a little bit, John, if you don't mind. These are my disclosures. So I don't have to tell anyone in this room, cardiovascular disease is just a rampant epidemic. It's responsible for about 1 out of 3 deaths around the world, more than 19 million people a year. But that being said, neither PCI nor CABG does a great job in reducing mortality from coronary artery disease unless we're treating acute coronary syndromes. And we thought that we were going to address this and do a better job in the most recent, biggest study ever, the ischemia trial, of which I was one of the co-principal investigators. And we randomized 5,179 patients with moderate or severe ischemia and chronic coronary syndromes to a revascularization approach with either PCI or CABG as appropriate, not randomized, or watchful waiting. Don't even do an angiogram. And these patients had documented coronary artery disease by a CTA. And in the invasive arm, 60% had PCI, 20% had CABG, and 20% either had mild enough or severe enough disease that they couldn't be revascularized with either therapy. And we were really disappointed that we saw, with follow-up out to 5 years, there was no major difference between a revascularization approach and watchful waiting with best medical therapy in chronic coronary syndromes. And in case you're wondering, like I said, this wasn't a randomized trial of PCI versus CABG, but in that regard, they did approximately equally when you adjusted for baseline characteristics. So we have to do better as 2 subspecialties. Now, we did make people feel better, okay? We made them more likely to be angina-free, we improved their quality of life, but we didn't reduce cardiovascular death, all-cause death, or myocardial infarction. So why is this? The reason is most of what we're revascularizing in chronic coronary artery disease is lesions that look like this. And when you look at these pathologically, they're what we call garden variety atherosclerosis. They're pathologic intimal thickening or fibrotic disease or fibrocalcific disease. And these lesions stay stable for decades. They rarely go on and thrombose and occlude. So they don't cause death and myocardial infarction, although they certainly cause angina and dyspnea exertion, which is why bypass surgery and PCI will relieve those symptoms. But we don't prevent death or NMI. In contrast, we want to prevent these kinds of lesions from progressing that causes a STEMI. This patient didn't make it, and his pathology shows a ruptured thin cap fibroatheroma, which is a totally different pathology than I showed you on the last slide. This is a lipid-rich plaque, which is often non-obstructive. You can see this is only taking up about 30 or 40% of the total coronary artery wall, and it's got this thin fibrous cap on top of it, and when it ruptures, it releases a lot of prothrombotic contents of the lipid core, and you get sudden thrombosis. Now, pathologically, you can identify these things, and they look like this, and then when they rupture, you suddenly get an occlusive thrombus. So we've always, and I've been running a vulnerable plaque meeting for 20 years now, and we liken these things to volcanoes because you could see this big fibroatheroma or necrotic core of cholesterol and cholesterol esters and dead inflammatory cells, which is about to burst through this very thin fibrous cap and then thrombose. And so it's like a volcano. You can't tell from looking at the surface of the volcano whether it's dormant or it's about to erupt and cause a lot of problems. And you can't tell just from the angiogram. Now, fortunately, we can tell by intravascular imaging. So we have a variety of tools from intravascular ultrasound to optical coherence tomography and near-infrared spectroscopy, where we can create pictures of the plaque and differentiate plaques that look exactly the same by angiography into ones that look benign, mostly this green color, which is fibrotic or fibrocalcific disease, to this red color, which is a necrotic core. And if we can also measure the thin fibrous cap, at least with OCT, with NIRS, we can look at a lot of this lipid. And we did the first study to actually show that you can prospectively identify lesions that cause cardiovascular death and MI. And we did a study called Prospect, which was published in the New England Journal about 15 years ago. And we took a total of 700 patients after an acute coronary syndrome. We stented everything that looked to be a severe lesion. And then we did 3-vessel imaging with those types of imaging catheters. So here was a vessel from the circumflex in one of these cases, and I'm going to tell you that a year later, this patient's going to have a non-STEMI due to somewhere in this vessel. Now, no one's going to do PCI in this vessel. No one's going to bypass this vessel, okay? And I'm going to tell you there's a problem in a year that develops that causes an MI. So where's it going to come from? You're probably going to look at this 30% or 40% narrowing and going to say it came from there. And the answer is no, it didn't. Okay, it came from more distally at this 10% stenosis. And what we did here at this stage, we did intravascular imaging of all 3 coronary arteries, and we found out that that 10% lesion was actually a very severe, bulky fibroatheroma. And when we did multivariable analysis, it was this type of lesion that leads to the types of acute coronary syndrome events as you saw in this patient. The first thing we learned from looking at those lesions is that even though the lesions look mild on the angiogram, like that 10% that I just showed you, when you image them, they're not mild. In fact, they're very severe. And it's not until you get to about 70% plaque burden from the inside that they're likely to cause events. And about 10% of these patients, 10% of those lesions caused an acute coronary syndrome within 3 years. By angiography, by core lab QCA, they were 32% stenotic. We're not going to touch those with PCI, and you're not going to bypass them. But these are the lesions that are causing problems. So we exploded a myth in this study that so-called vulnerable plaques are not mild, which is what everybody thinks. They are actually severe, but angiographically they look mild, so you have to stop relying on the angiogram. We need tomographic techniques that can look inside the coronary artery. The angiogram's a terrible test for this. But we need more than just plaque, because some of the plaque is very stable, like that first case that I showed you, while other plaque is actually the type that goes on and causes these events. And when we broke down the plaques, and this was all a prospective blinded study, into those that were thin cap fibroatheromas, thick cap fibroatheromas, and all the other types, fibrocalcific disease, etc., those lesions don't give you any increased risk. It's not until you get to a fibroatheroma, especially a thin cap fibroatheroma, that you've got a very high risk of having a future acute coronary syndrome from a mild appearing lesion within 3 years. We then ran a second study called Prospect 2 in 900 patients using a different imaging catheter that looks at intravascular ultrasound and lipid with spectroscopy, and we found the exact same thing. So look at this right coronary artery. We stented down here, but then you've got these 2 other long segments of 10 or 20% stenosis. We do an FFR, and it's normal, okay? So no one's going to touch those lesions. But in this case, in 3 years, this patient presented with a non-ST segment elevation MI with rapid progression in thrombosis right at that big white arrow. And when you looked at what that looked like at baseline 3 years earlier, that's where all the lipid was. Okay, the rest of it is red, which is basically no lipid. And notice none of that changes. It's only where all this concentration of lipid is. So these are vulnerable plaques. So can we identify vulnerable plaques that place patients at risk for future acute coronary syndromes? Yes. We now have, it's not just our studies, we now have 9 prospective studies that have validated this. So what do we do about it? Okay, well, here is a patient, a 66-year-old diabetic woman, atypical angina. She was treated with medical therapy, and because she had atypical angina, she got an angiogram. And her coronaries looked perfectly normal except for this mild 30% mid-LAD lesion. So she had atypical angina. The doc did an FFR, and the FFR was 0.88, which is normal. So this is not causing her angina. It's not causing any ischemia. So he left her alone, and 3 months later, she closed that lesion and presented with a massive STEMI. And then they decided to image it. After the time when they did the primary PCI, at the time of the STEMI, and they found it's 360 degrees encircled by lipid with all a thin cap. This is an OCT image, and then there's the ruptured plaque, and it's full of thrombus. So should this be treated? Should you put a LIMA on this? Should you do PCI on this? More intensive pharmacotherapy? What do we do? Well, we and others have had the idea for a long time that if you take one of those thin cap fibroatheromas, you could put a stent on it. And the stent heals by forming some scar tissue. And that would actually serve to thicken the cap on top of the lipid and protect it from the bloodstream. Where if you just leave it alone, it might rupture. And so here's another image from our studies, 10% ostial proximal LAD stenosis. Okay, huge amount of plaque, huge amount of lipid, but no one, of course, would ever consider treating this. So we did a pilot study where we randomized 182 of those types of lesions to either putting a stent or a scaffold on them or leaving them alone. And what we found was that we could safely enlarge the lumen. We doubled the size of the lumen. We brought the patients back at 2-year follow-up. At 25 months, we doubled the lumen size. We created a new cap of that scar tissue of 210 microns, which is very small, but what we wanted. And we were able to delipidate the lesion, okay, by doing the intervention. And now this trial was only 182 patients. It wasn't powered for clinical outcomes, but when we looked at what happened to those randomized lesions, we had a pretty strong trend towards a 60% reduction in MACE. So I then, because we couldn't get funding in the United States, I worked with an excellent group in Seoul, Korea, that have run a lot of large-scale randomized trials, including the pre-combat trial. And we ran the PREVENT trial. And this was the first, and so far to date, only vulnerable plaque trial that's been powered for clinical events. And we took 1,600 patients with an epicardial coronary diameter stenosis of 50%, but with an FFR that was normal, so not obstructive, okay? And they have to have 2 or more vulnerable plaque characteristics by these intravascular imaging techniques. And then they got randomized to a stent or a scaffold versus just medical therapy alone. And the primary endpoint was target vessel failure at 2 years, and there was a 90% reduction in clinical events from vulnerable plaque treatment, what they call preventive PCI, from 3.4% to 0.4%. What were these events? There's the TVF difference. There were trends towards everything being reduced. Most of these events were ischemia-driven TVRs and hospitalization for an acute coronary syndrome, but there also was a reduction in death or target vessel myocardial infarction. Now, there's a lot of reasons to think that this trial could have been even more positive. Okay, when we follow these patients out for 7 years, it stayed positive with a significant difference out to 7 years. But it could have been more positive because the majority of the lesions, they qualified with just grayscale intravascular ultrasound. And when they did that, there was actually no difference. But when they used a test for lipid or a test for a thin fibrous cap, that's OCT or NIRS, then they had a huge difference in events. So the results could have been even better. So there's a lot of other studies that are now ongoing about vulnerable plaque. There's 4 more, okay, that are randomizing anywhere from 600 to 5,000 patients. These studies are all underway, and in the next several years, we should get the results of these trials. So I'll close with just one provocative case. Should we look for and should we revascularize vulnerable plaque? This is a 65-year-old man. This patient was actually the CEO of a Fortune 500 company. He had exertional dyspnea. He was a prior smoker, hypertension, hypercholesterolemia, reasonably well-controlled LDL on atorvastatin. He had a stress echo that showed a millimeter of ST segment depression, but no changes in wall motion. But his doc said, okay, you're a very important person, so we better do an angiogram. So they do an angiogram, and his coronaries were normal except for these 20%, 30% lesions in his proximal and mid LAD. So now what do you do? Okay, well, let's make sure this is not causing your exertional dyspnea. So let's do an FFR. And his FFR was 0.88, where 0.8 is normal, 0.88. So this is not causing his exertional dyspnea, and he's got mild coronary artery disease. So now what do you do? Well, he's a very important person. So let's do intravascular imaging. And they did intravascular imaging, and both of these are severe vulnerable plaques. They're highly lipidic, they're very bulky plaques. They look mild by the angiogram, but they're 70, 75, 80% stenotic by intravascular imaging. So now what do? These are widowmaker lesions. We know what their prognosis is from prospective studies. Should revascularization be performed if an informed patient agrees? This would be class 3 by all guidelines today to revascularize these patients. So I have to say, we're not going to do that today, but maybe we're going to do it tomorrow. Thanks very much.
Yeah, Greg, thank you very much. Are there
I'll come back.
questions?
Yeah, I'd ask a question.
Sure.
So, what you present is pretty convincing data. But supposing you could demonstrate calcification on, say, CT angio or otherwise, would that make you feel safer on these lesions?
So if these lesions were heavily calcified, they won't look like that by intravascular imaging. And the heavily calcified lesions tend to stay stable for decades. These are, as you can see, there's no calcium in these lesions. They're very soft, lipid, rich plaques.
In the PREVENT trial,
Yes,
the ones that were stented,
right.
what is their reocclusion or restenotic rate?
So the restenotic rate was 2%. 2% restenosis.
Okay.
Reocclusion rate, there were actually no reocclusions.
John?
Wonderful presentation, and thank you again for being here, Greg.
Sure.
It's wonderful to have world-renowned interventional cardiologists and trialists participate in the International Coronary Congress.
Thanks, John.
We're grateful for your presence. Thank you. Quick question. When I look at this, I immediately start thinking about the advanced photon counting CCTAs and plaque analysis by the ever-evolving and ever more sophisticated non-invasive measures. What is that going to do to this thinking and to this concept and even to the therapy that you're proposing?
Yeah, so obviously the resolution is better for photon counting CT, and there's less artifacts from calcium. Calcium causes blooming. You get false positives in MSCT. Even before photon counting CT, we're starting to get evidence that multi-slice CT is a reasonable way to assess vulnerable plaques. It's only got a resolution around 500 microns, so it's not great, but it'll probably come down to about 300 microns with photon counting CT, so it will only get better. So it can be used as a screen for vulnerable plaques. Then you would probably go to the cath lab, you would confirm it invasively, and then decide what kind of treatment the patient should get.
Yeah, so that's probably a very good point. There's a critical comment that I may maybe be able to make after the compliments that John just advanced. The explosion in the recognition of that the non-stenotic lesions actually cause the problems, I don't think that's a new recognition. That's something that we have addressed many years before, and I'm glad that actually arrived at the interventional community. Yeah. But the concept is right, and this, what you showed, only goes to show that we need to collaborate, because you have shown a series of patients that are not surgical candidates, and that's where there is no competition. There's only room for cooperation. Thank you.
Couldn't agree more.
Thank you. That was really thought-provoking.
Okay, so we're coming up to the next speaker. It's going to be another interesting and fascinating topic. It's Subodh Verma. Subodh, we're happy to have you. And the title is The Medical Therapy Revolution in Coronary Artery Disease. Where are we in 2025? We're curious. Thanks.
Well, thank you so much to both of you. And John, many congratulations to you and the organizers for an absolutely fantastic meeting. I heard this is, you've got, close to 800 registrants at this meeting, so congratulations. For those of you who haven't actually bought your pin, I would encourage you to do that. I was at the registration desk this morning, and there's the Founders Fellowship. So those of you who can and have capacity and would like to contribute to the Founders Fellowship, please make a donation and get your pin and wear it proudly. So I would like to really extend the conversation that Dr. Stone has put forward and make the argument that, identifying vulnerable plaques and targeting vulnerable plaques with interventional strategies is critically important. But those strategies also need to encompass maximum medical therapy, because maximum medical therapy is pivotal in terms of stabilizing plaques that we can't, as coronary surgeons, revascularize. And many of the recurrent and recalcitrant ischemic events that occur in patients following bypass surgery are often a result of inadequate and suboptimal secondary prevention strategies. Now, coronary surgeons have often not taken medical therapy that seriously because we're surgeons. We're invested in innovations in terms of surgical technique per se, but we are certainly losing the battle, if I may, if we don't really understand the value of these additional complementary strategies and force ourselves respectfully to make these part of our vernacular. We have to do that. And this is what I'm going to try to argue over the next sort of few minutes. And I really would like to give credit to John for actually forcing this topic into the Coronary Congress for the last few years, trying to really raise our understanding and standard of many of the things that influence outcomes. Now, a lot has been written about this, that secondary prevention is just as important as the surgical technique. And in fact, if you look at our own literature from JTCVS and Annals, papers that we usually refer, journals we read, the surgeon's role in optimizing medical therapy is important. Suboptimal medical therapy after coronary revascularization is a problem. And when we debate PCI versus CABG, as you all know, secondary prevention pharmacotherapy adherence and secondary prevention pharmacotherapy utilization is higher in the PCI group compared to the CABG group. And therefore, right off the bat, even if you're doing the calculus of CABG versus PCI in people living with diabetes and showing a 20% superiority, that superiority would probably be much larger if actually people were truly taking the secondary prevention therapies as compliantly as patients who undergo PCI and are seen by cardiologists. So the secondary prevention guidelines for post-CABG patients are dated. These are 10 years old. I'm pleased to inform you that the new 2025 guidelines from the ACC-AHA will be forthcoming. A few of us under Mark Ruel and Sigrid's leadership have put those documents together, and they should be published in short order. So that will hopefully bring up to speed, what is the cocktail for secondary prevention in patients following bypass surgery. So, the calculus is complicated, the list is complicated, but it's not as complicated as the intricacies of robotic surgery. So don't tell me that we can't learn a few names and figure out how to implement these if we can do complicated operations. So antithrombotic therapies, we all know, foundational therapy with aspirin, low-dose aspirin, no value of high-dose aspirin in these patients. Their dual antiplatelet therapy to improve graft patency. Some controversy in 2025 regarding the use of dual antiplatelet therapy for 1 year following bypass surgery in patients who were admitted with an acute coronary syndrome. And of course, the potential for dual platelet inhibition with aspirin and low-dose rivaroxaban in patients who have polyvascular disease. So at the ESC meeting 2025, there was the TAXI results presented, and this was published in the New England Journal of Medicine. This is one update for all of you from 2025, and that is that patients who have revascularization in the setting of a recent acute coronary syndrome, where in the past we suggested that these individuals should receive dual antiplatelet therapy for 1 year following bypass surgery, that in a prospective randomized trial did not offer any additional benefit, but it did come with a bleeding risk. And this has certainly changed our guidelines at the University of Toronto, wherein we don't necessarily, by default, prescribe dual antiplatelet therapy following Revasc if someone has not had, let's say, an endarterectomy or something like that, but if they've just come in with an acute coronary syndrome. Now, Deepak Bhatt and I were involved in leading the Ventracimab program. Rich was also involved in that program, and this is in front of regulators right now. So this is the antidote to ticagrelor. This immediately reverses the effects of ticagrelor, and I think will hopefully become available soon and should make the timing of surgery and balancing ischemic versus bleeding risk more favorable. Many of us often struggle with emergent situations where ticagrelor reversal is required. Once you get to 2 or 3 days post ticagrelor, I think most of us are quite comfortable with those patients, but having access to Ventracimab, I think, will be important. Now, the story of LDL cholesterol lowering is one of, a really rewarding one. Lower is better, lowest is best, 0 is probably even better. And that story has evolved over the last 3 decades. And if you look at, again, the 2025 guidelines, as John had requested, I just want a 2025 update, the ESC guidelines have now suggested that LDL cholesterol levels in people with extreme risk, i.e., people defined as having, let's say, a Revasc in the context of an ACS, or someone who's got polyvascular disease, or someone who has atherosclerotic disease with CKD. These are our patients all the time, right? The LDL cholesterol thresholds there are 1.0 or below, and that would be, 25 mg per deciliter, right? So we're looking at very low LDL cholesterol levels if you live in Europe in people with extreme risk. And for the bread and butter patients with, ASCVD, levels of less than 1.4 millimoles per liter. Now, we also recognize the fact that moderate to high intensity statin therapy remains the backbone, and everybody is on it. Not everybody is optimized. But the question about whether or not we should add, PCSK9 inhibitors. Now, I hope all of you know that there are 3 injectable PCSK9 inhibitors, and there are 7 oral PCSK9 inhibitors that are currently in development. And I'm involved in about 4 of the large trials of oral PCSK9 inhibitors that will hopefully change the landscape. At the AHA, we presented the results of the Vesalius trial, and this was a trial of people with a history of ASCVD who had not yet had an event. And a large proportion of these patients were people with a history of bypass surgery. So patients with athero or Revasc who had not had a prior ischemic event. And the question was, would intensive LDL cholesterol lowering with evolocumab, a PCSK9 inhibitor, to LDL levels of about close to 40 mg per deciliter or 1.2 millimoles, would that further reduce events? And you can see here that over 4.5 years, there's a 25% reduction in MACE, and there is actually a 20% reduction in all-cause mortality. So LDL cholesterol lowering, even in people who have not had an acute event, who either have athero or diabetes, pays dividend, and goes back to smart people who actually won the Nobel Prize for LDL cholesterol. This is Brown and Goldstein in their paper in Nature that suggested, when they identified the LDL receptor, that probably a level of 25 mg per deciliter is all that you really need. Everything beyond that is pathologic, and that is consistent with what the clinical trial data have actually demonstrated. In 2025, we reported, Rich Whitlock is a co-author on this paper with me and Dave Mazur. We actually thought that intensive LDL cholesterol lowering would be beneficial in terms of early graft patency. And unfortunately, these data suggested that whereas long-term LDL cholesterol lowering is efficacious, short-term, 2-year intensive LDL cholesterol lowering with evolocumab did not result in improved graft patency in these patients. Along the lipid sphere, triglyceride targeting remains quite important. Many of our patients living with diabetes have elevated triglycerides, and icosapent ethyl, or Vascepa, has been shown in the REDUCE-IT trial to really reduce cardiovascular events and MACE events. And in people with a prior history of CABG, there is a 31% relative risk reduction for major adverse cardiovascular events. Now, the language of diabetes has completely changed, right? The days of sulfonylureas and metformin now being downgraded to sort of third or fourth line therapy, thanks to the SGLT2 inhibitors and GLP-1 receptor agonists, have been transformative for cardiometabolic risk reduction. And I think all of you should remember, or as you probably know, that every patient living with diabetes should be on one of these agents, if not both, even if their A1C is normal, for cardiorenal and metabolic protection. Now, I was involved in the SGLT2 inhibitor stories all from the beginning, from EMPA-REG outcome that Bernie Zinman led from the University of Toronto. In people with a history of bypass surgery, there is a reduction in cardiovascular death and heart failure hospitalization, and the GLP-1 receptor agonist story with semaglutide and all of its brothers and sisters, the G, double G, triple G, tirzepatide, retiretride, survodutide, MariTide, are all coming. And many countries, including India, as you probably know, Naresh, are actually going to be introducing generic semaglutide very quickly, as is Canada. Semaglutide reduces MACE events in people with diabetes, reduces coronary revasc, and also reduces outcomes in people without diabetes living with obesity. I think the inflammation story and its trials will really complement what Dr. Stone discussed earlier, because inflammation appears to be the real tipping point for vulnerable plaque and plaque rupture. There's some data with colchicine that remain controversial, but the 2026 will see the results of the ZEUS trial. We've been working on that for about 5 years now, and that is with ziltivekimab, an IL-6 inhibitor in this context. Finally, the calculus for GLP-1 RAs in people without diabetes and BMIs of over 27 has been quite strong. The data from SELECT trial demonstrating that there is a reduction in MACE events. We have shown that in the subgroup of patients with CABG, in the SELECT trial, there was a further 20% reduction in outcome, i.e. someone who doesn't have diabetes but has a BMI of over 27 post-CABG should ideally receive semaglutide to reduce MACE events. And in the very last comment around PAD, I know this is not a PAD meeting, but it's an athero meeting. Mark Bonaca and I chaired the STRIDE trial that was also presented in 2025, and this was with semaglutide in people living with PAD. And PAD is a disease for which we have no solutions, really. People have, ongoing symptoms of claudication. You tell them, don't worry about your legs, we'll worry about your heart, and they look at you saying, are you crazy? I'm worried about my legs. So improving, walking distance and improving outcomes from major adverse limb events remain important, and we've seen that in the STRIDE trial and in the whole program that there is a 30% reduction in male outcomes, and this has triggered a large number of male and PAD trials. So to conclude, colleagues, really the integration, if I may, of medical therapies in patients following CABG or coronary disease is really important. And we know that statins and aspirin are foundational, but then we also have to understand that this is just the base case. The best case scenario needs to be informed by biomarkers, whether that biomarker is further LDL, CRP, whether it's thrombotic risk, obesity, diabetes. This is how we will move forward. So I will basically end by just saying the following final thoughts, and that is that modern coronary artery disease care demands, respectfully, that cardiac surgeons speak the language of contemporary pharmacotherapy. Secondary prevention should be part of our vernacular. We must champion implementation strategies that are practical, scalable, and seamlessly integrated into routine surgical pathways. And finally, to elevate our outcomes as cardiac surgeons, surgical innovation must be coupled with adherence to established and emerging pharmacological therapy. Thank you very much.
Actually, Subodh, one minute. Now, if you put together what Greg Stone said and what you're saying, would you propose that everybody should be on some sort of statin and semaglutide?
Well, I think that I understand the subtext here is I don't think everyone, but the vast majority should be treated, lipid lowering for sure, because it has very few downsides. It's available generically. Intensive statins have long history of safety and efficacy. And if you look at the cumulative data, I think we wait too long before we initiate statins. The biology of atherosclerosis progression is one of, delipidation of plaques, right? And the earlier you can do that, and the longer you can do that, the greater is your benefit. We saw that in Vesalius. When we designed the trial, we said there will be mandatory 5-year follow-up as opposed to an event-driven trial that ends at 2 years. So at 5 years, there's a mortality benefit, and prior trials at 2 years that have been event-driven have only shown non-fatal benefits.
So is it a myth that there are side effects to statins?
It is a
Long-term
myth.
therapy?
Respectfully, it is a myth. It's very well tolerated. There's no cancer risk. There's no hemorrhagic stroke risk. There's no cognitive. It doesn't make you smarter. I'm sorry to tell you that, but there's no cognitive decline per se. There is a small increase in biochemical transition to diabetes. That's 1 out of 1,000. But the overall benefits of statins clearly outperform.
So, Subodh, great summary. Thank you so much. The one thing that always comes up in these discussions on medical therapy is this is the end of CABG, because the coronary disease goes down and the patients don't have it anymore. So what's your prediction for the next 10, 20 years on CABG and the role of the surgeon?
Well, I don't think it's the end of CABG, but I think there's 2 ways of looking at it. Is first and foremost, many of these therapies that I've presented to you are secondary prevention therapies. So the implementation of this science will likely only occur by clinicians in the trenches in people who have established disease. No payer environment is willing to pay for these therapies early on in so-called primary prevention. But what is critically important is as the field of CABG versus PCI, really truly, it's not competition. It really is understanding what is the reality of the outcomes. There are lesions that that Dr. Stone showed you this earlier that are not amenable to PCI, and only trials that he's doing in the future might actually open the door to that. And then you're going to have to get interventionalists to agree to actually stent those lesions that are vulnerable. But we can treat all of those vulnerable lesions with many of these pharmacological strategies. So if we want to optimize our post-CABG outcomes, then innovation in surgical technique must be coupled with embracing this.
I think that's a very important part. And if we surgeons understand for now that the treatments are complementary, I think that is something that helps everybody. Great. Thank you so much.
Thank you. So we have some hope in what John is going to say. John, would you please enlighten us? So John's coronary care in 2030, guided by AI-enabled non-invasive imaging.
So this is actually a topic that I'm really fascinated by. The concept of non-invasive interrogation of the coronary arteries, and not just to identify stenoses that are flow limiting, but to quantify the degree of stenosis, and perhaps more importantly, to characterize the nature of the plaque and identify vulnerable plaques. I think this is truly the future. We're not going to use invasive coronary angiography for diagnosis for very much longer. That's the conclusion of my talk. And this is the whole talk in one slide. The end of diagnostic coronary angiography is near. And this is not a complex rationale. Invasive coronary angiography is a static, mature technology that's older than almost everyone in the room. By comparison, computed CT angiography of the coronary arteries is a relatively newer, rapidly evolving digital technology. And there are massive improvements in both hardware and software that are ongoing and accelerating. Thus, this is a much more information-dense or information-rich technology. While invasive FFR improves outcomes with PCI, we know the role for FFR to guide CABG is less clear, but non-invasive FFR is well established and validated against invasive FFR. So what you can learn with a catheter, I think you can also learn now with non-invasive techniques. I think it's important to remember the Syntax 2 2020 score. This is an algorithm that has been validated in invasive angiography, and it can predict outcomes with alternative medical therapy, PCI, or CABG for specific patients with multivessel disease. More recently, artificial intelligence has been layered onto this to create the Syntax 2 2020 machine learning algorithm, which continues to evolve under the creative design of Dr. Patrick Sorois, perhaps the only other cardiologist in the world more famous than Greg Stone. Complex complete revascularization by all arterial CABG is already possible using only preoperative CCTA, and I'm going to show you images from the Fast Track trial that prove that. This is a Cine frame from the very first angiogram ever done. It was an accident. Mason Sones accidentally got a catheter into the right coronary artery trying to shoot an aortogram on October 30th, 1958. Notice it doesn't look very different than the ones we use now. We haven't seen that much improvement. And let me point out the date again. This is 1958. By comparison, this is what a high-resolution energy integrating detector, CCTA, will generate. This is the GE Revolution scanner with HeartFlow analytics. We can get specific images of the coronary arteries at each of their locations. We can identify and measure the extent of stenosis, the linear distance between the stenoses, and then we can create through AI. This is an FFR map of those same coronary arteries. So while in the past, from 1958 to the present, we've had this, what I now call a legacy care pathway, where the gate is interventional coronary or invasive coronary angiography to make the diagnosis of coronary disease, and then to decide therapy being medicine, PCI, or CABG. That has left the gatekeeper role to the interventional cardiologist. I believe in the future we will enter a different care pathway, a non-invasive care pathway, where the gate will be CCTA. The diagnosis of coronary artery disease will be made and characterized by that, and algorithms that will be based on massive data samples will advise patients and practitioners whether medical therapy, PCI, or CABG is best therapy for that patient. And in different locales and perhaps in different time frames, the gatekeeper role will change. But I believe it's no longer going to be uniform to the interventional cardiologist. So this is a paper that I recommend to you. It's Dr. Sorois in JACC in 2021 that documents the external validation of this predictive algorithm. Basically, it says that the Syntax score 2 2020 does predict 5-year death and MACE events accurately. And this is a really fascinating, this title, read the title and then look who wrote it. These are interventional cardiologists saying that we're going to replace coronary angiography with coronary CT angiogram with functional evaluation. And this is published in the European Heart Journal, not the European Journal of Cardiothoracic Surgery, but this is a cardiology journal 5 years ago. Now, more recently, also in the European Heart Journal, just last year, Dr. Sorois published the Fast Track trial. And what this trial basically did, it took 114 patients at many centers, including the center where Dr. Dunst practices in Jena, Germany. These patients were referred with multivessel coronary artery disease to have CABG by conventional guidelines. They agreed to, in addition, have a non-invasive CCTA. The operating surgical team only saw the non-invasive CCTA in planning and performing the coronary surgery. And then a month post-op, the same patients had another CCTA to calculate residual syntax score. In other words, we're testing, can we safely design and perform a coronary bypass without seeing an invasive coronary angiogram? And a month later, will the patients have been well revascularized? So this is the very first patient I did in this trial. We were the only center in North America participating. This was fundamentally an international trial outside the United States. And this is the preoperative angiogram, which I did not see prior to surgery, but which shows you that there's a lot of coronary disease in this patient. Pretty clearly what we would consider surgical disease. Now, on the left is the coronary angiogram, which I did not see, and on the right is the CCTA, which I did see. And although this kind of breakdown and analysis is presently very labor intensive, and you don't generally get this when you order a CTA, it is doable. This represents hours of labor of a non-interventional cardiologist interpreting these data. It will soon be automated. But these are the kind of images that I use to plan this operation. And you can see exactly where the lesions are and how tight they look. I mean, this is pretty good guidance. And as I said, this is the very first patient. I had operated on 0 previous patients based on CCTA. And I'm telling you from the very beginning, you can do it. It's easy. These roadmaps are good enough. And you can see those lesions, well, they're demonstrated here. You can measure the distance between them, plan your graphs based on this linearized image of the coronary artery. You can decide which kinds of arterial graphs you want to use in which configuration based on the relative competitive flow in the native coronaries. This is the circumflex artery. The first one I showed you is just the LAD. Here are the images for the circ. And here's the CCTA of the circ. Again, tells you right where the lesion is, how tight it looks, and then we get the CT-FFR measure of the tightness of disease. You can see this patient had a lot of disease. Here's the right coronary artery. Again, we did not see these invasive angiograms prior to surgery. We saw these instead, and they were adequate to plan and conduct the operation. Here's the FFR of that right. So the functional syntax score for this patient was 66, clearly putting him in the surgical camp. Interestingly, the algorithm, the syntax score 2020, told us that the 10-year mortality would be an absolute difference of almost 20% at 10 years, and the 5-year MACE would have an absolute difference of about 20% if this particular patient had multivessel PCI versus CABG. We had to submit a case report form saying what we planned to do for this patient. As you know, my routine is double mammary inflow and multiple arterial outflows. We opted for this strategy based on that CCTA, and then that's actually what we were able to do in the operating room. And as I reflect on this first case, I will tell you that I used the CCTA anatomy images much more than the FFR numbers, and was able to perform my routine kind of surgery. So this did not change what I did in any way. I would have done exactly the same thing had I done it based on an invasive angiogram. Here's the 1-month follow-up scan. There's the LITA that goes to the diagonal and the LAD. Here's the radial artery coming off the LITA to the obtuse marginal. Here's the right mammary extended with a piece of radial to reach the PDA and the posterior marginal. Exactly what we would have done with an invasive angiogram, and here's a residual syntax score of 2. So we're able to take a syntax score of 66 and make it 2 without ever seeing an invasive cath. So if you're asking yourself, can this be done? The answer is yes, we did it the first time. And we didn't do a simple operation, we did our usual pretty complex operation. It was actually easy to use this. It wasn't any harder than doing a normal operation. Now here's an interesting paper by Mario Gaudino, also in the European Heart Journal, asking the question is coronary angiography and coronary bypass, are they going their separate ways? Are there other options? And I think the answer is yes. But as Dr. Stone mentioned, photon counting scanners are getting even better because the Traditional energy integrating scintillators have a two-step conversion. X-rays are converted to light, and that light beams are converted to current and makes digital images, but photon counting scanners actually have a single step. X-rays become directly converted to current, and this produces a greater detector capability. The resolution is down to about 200 microns. It eliminates electronic noise. Spectral sensitivity is improved, and as a result, the amount of contrast media needed is much reduced. Now, for temporal specificity or resolution, normally scanners are a single source and they have to rotate 180 degrees to make an image, but the next gen ones are dual source and they rotate 90 degrees. So you can double the temporal resolution in making images of a moving target like a coronary artery. So with dual source CT scanning and photon counting technology, there's another problem of this thing called stair stepping, and that can be obliterated or removed largely with post-acquisition data analytics. So the bottom line is that we're getting to the point where photon counting CT scanners with dual source or more than two sources plus AI is going to produce one-stop shop information that's going to be augmented with AI to achieve this thing we call AI-enabled quantitative coronary plaque and hemodynamic analysis. This is the EMERALD trial that really made that a reality. So I think this is where we're going. We all need to get ready for it. I think it's going to lead to some very interesting things. One of the things it's going to do, I think, is it's going to mean that we start to operate for patients who haven't yet had an MI. It's going to make both medicine, PCI, and CABG more preventive rather than responsive. And I think that's going to be good for patients and practitioners. My prediction is it will lead to more PCI and more CABG and many fewer PCIs or CABG after myocardial infarction. Thank you.
Go ahead, John. So far this session, which is the most stimulating you can find, because otherwise we are discussing our routine again and again. What we are saying is that many things will be turned on their head very soon. So 2030 would be a very interesting meeting to really come out with the impact of what all of you guys are predicting.
It's going to change a lot of people's lives, patients and practitioners. Like if I were a nuclear scanner reader, you know, a PEC scanner, a SPEC scanner, some nuke scanner guy. I mean, I told the heart center at Emory, I said, sell them. Get them out of the building while there's still a resale value for your nuclear cameras and install CCTA. Now, the chief of cardiology makes his living doing nuclear scans. I said it directly to him in the board meeting. We got to sell those machines. They are antiquated. They have a resale value now. They will not in 3 years. You will literally have to pay someone to take them out of the building and throw them away. You can sell them for something now.
Well,
We have 2 photon counting scanners on order. They're in such high demand that you have to wait for them. And they're $2.5 million a piece.
so I think the only stable thing in life is change, and we need to change to the next presentation. Thank you very much. So the next person doesn't really need an introduction. Volkmar Falk, the head of the German Heart Center of the Charité in Berlin, and immediate past president. And there's one thing I want to say is he is probably one of the most innovative surgeons I've ever met. He has always been ahead of the community, and the one feature is that he introduces, or he whatever he recognizes, he actually puts into practice. And for those of you who want to know what that means, is just take a look at his new building in Berlin. And so with that, I'd say that he is exactly the right person to talk about the next title, and that's CABG in 2030. Can surgery stay ahead of technology? So, Volkmar, please.
Thank you, Thorsten, for this kind introduction. First thing I have to announce is I wasn't quite clear about the title, what it actually means. And it will be a little bit disappointing because I will not specifically new technology, talk about new technology. So if we talk about the future of CABG in general, we have to look at the framework that we are working in. And the framework, as I can see it, looks good on the first hand. This is just a map of Germany. It shows you an aging population. More age means more disease, and you can see in the lower left graph how that translates. There's an increase in valvular heart disease, coronary artery disease, heart failure, you name it. The thing is, and that would be the expectation, is should translate into more CABG patients as well, so good business for all of us. The truth is that better prevention, better drugs, and better diagnostics has already led to a decrease in coronary artery disease. So at least in Germany, and I think in most countries, this slope actually declines. So as a matter of fact, while patients get older, we see less patients with coronary artery disease. And this translates also in a static decline of CABG, at least in Germany. These are the numbers. We lost about 44% of case volume when you look back all the way to 2006. And just for the last 5 years, it was a decrease of 15%. So after COVID, more or less. So this is a dramatic decline. And the question is, can we do anything about it? Or maybe it's a good sign that we have better other treatments that cure the disease. So when we have to think about how can we maintain this business of CABG and what are the goals, what do we want to achieve really? Of course, it's 4 things. We want to build a collateral arterial coronary network, achieve complete revascularization, provide a prognostic benefit, and achieve these goals with a minimum of trauma. I think these are the 4 goals that we all share. Let's have a look at the first 2. You are familiar with these simple graphics that show the basic difference between a bypass graft and a stent. And after the discussion that we just had about vulnerable plaques, it is obvious that this concept, which basically Thorsten popularized over the last couple of years, has its merits. So because a bypass graft by its nature bypasses not only a stenotic lesion, but also a number of vulnerable plaques. And the collateral arterial network that we want to construct, you can see here. And of course, if he has multiple arterial inflows into the coronary system, that ultimately should create a benefit, not only by bypassing vulnerable plaques, but also increasing the net flow of blood. This was mentioned earlier in the talk. The severity of stenosis and the future risk of myocardial infarction do not correlate. Most myocardial infarctions come from vulnerable plaques that are not severely stenotic. And that is exactly the reason why bypass graft, by bypassing vulnerable plaques, prevent future myocardial infarctions. And this is something that you can see in every single trial comparing CABG and PCI. This is just one of them in the patient meta-analysis for left main 5-year outcomes. And you see the huge difference in myocardial infarction, which is basically the driver that makes CABG better than PCI in the long run. Now, we want to provide a prognostic benefit, and we do that against medical therapy, but we have to admit this medical therapy that serves as a comparator is pretty outdated. I'm not sure if we would run the same trial today comparing CABG against optimal medical therapy, as we just heard in the previous talk, would show the same results. But for now and for the guidelines, this is what we have. We do a better job than PCI here, and we do a better job than medical therapy. For PCI, also, you know the literature here, just one of the many papers that show that for triple vessel disease, we can still do a good job, which has a prognostic benefit for these patients. Now, as I said, we need to achieve these goals with minimal trauma, and that relates also to patient expectations. Now, what does the patient expect from us? Basically, if you ask patients, this is the wish list: no pain, no incision, short hospital stay, or no hospital stay, no morbidity. Especially stroke is considered worse than death by most patients, and they want a fast recovery. Now, do you see prognostic benefit here on this list? I don't see it, and that comes very rarely. So it's all about trauma, and then maybe if you can get that with prognostic benefit, so much the better. And in 2000 already, Michael Mack, in his seminal paper here, the future of minimal invasive and robotic surgery formulated the future of surgery, which is ablation over excision, image guidance over direct vision, reconstruction without suturing, access via natural orifice or blood vessel over incision. So if this is the future of surgery is PCI, because all that is PCI. Now, patient expectations, we have to make them our performance goal. And we, as surgical community, often are in a state of denial. I mean, we still talk about sternotomies and all that. I mean, people don't want that. I mean, anyone in the room does want a sternotomy? I don't want one. So this cannot be, even if we have prognostic benefit, this cannot be the future of CABG. And it won't, for many reasons. Now, what still can we do? How do we get there? And of course, we've seen a couple cases already this morning. So one good option is mid-cap. Of course, you know how it works. No cardiopulmonary bypass, no sternotomy. And the one thing that convinced me about mid-cap was that those patients typically never have a stroke. I've yet to see a mid-cap patient with a stroke. I mean, it just doesn't happen. You don't touch the aorta. You don't do anything to the big blood vessels. There's no cardiac arrest. So why should that patient get a stroke? And they actually don't. So that's a good thing. So this is one operation that has its merits. We can combine it to reduce the trauma, do a minimal invasive Lima takedown, combine it with PCI for hybrid procedures. I think for many patients, probably a very good option, Lima to LAD and some hybrid grafts, some PCI to other lesions. Now, the robotic cardiac surgery is in evolution. For many years in Europe, we didn't do much because we didn't have the outcomes that will support the concept. Also, we didn't have the regulatory in place to do cardiac surgery. So we were really cut off this development for many years, but we're coming back now. And we can see a relaunch of a platform that can be used in cardiac surgery next year. The robotic surgery landscape is changing, so it's many platforms. We saw 2 examples today, so it's not just a single company, it's many companies. And of course, you've seen a beautiful case by Gianluca today, and I would think that this is an operation that many people can do. The new platforms will enable us to do this, so we actually come close to a PCI-like trauma. Still, the patient will need anesthesia, still there's some trocars involved, but remember the paradigm of Michael Mack, no big incisions, and I think we're coming close here. Now, the other thing that we need to keep in mind is that we also have to admit that we somehow have to address the fact that we not all do the surgery the same and that we are not skilled the same. And you all know the volume outcome relationships that we have. So large volume, better experience, higher quality. And this is true for institutional volume. Here's just 2 examples from 2 different studies that show that. So low case volume is almost a CABG lottery. So the results that we all claim to have, they don't apply to all of us. They apply to some. And we have to, as a community, discuss how we get there and what is the solution to this. And this also applies to surgical volume, surgeon volume. So on the individual level, the same. We have a relationship between volume and outcome. And of course, things like this, multi-vessel, small thoracotomy, beating heart revascularization are not for everyone. Despite the fact that we're showing these cases here, I don't think that every surgeon can do that. Same is probably true for multi-vessel TCAP. And look at this microaxial flow pump assisted CABG in patients with low ejection fraction. Another thing that we're currently doing to prevent those patients from having any ischemia and get them stable throughout the operation. This is clearly one thing that helps patients with an ejection fraction of less than 20% to get safely through the operation, stabilize them over the course of the ICU, and then have them optimally titrated with heart failure medication before you discharge them. So that is something that we currently do, but I don't think you can do this in every center and every surgeon can do this. That's why Dave Taggart and Michael Mack long ago defined asked the question if coronary surgery should be a subspecialty, and I think the answer is yes. You can only achieve improved outcomes with subspecialization in CABG, and there's a couple of things I would like to add to this chart here that is from a paper Watkins in Annals of Thoracic Surgery. We need to think about the patient before he comes in the hospital, prehabilitation programs. We need a post-operative recovery standard for the ERX. Image-guided surgery, as John just said, we need to think different about how we plan our procedures. And of course, we need to involve minimally invasive therapies. And to the lower right, QSUM analysis for quality outcome reporting on individual and institutional data. So standards, performance goals, and best practice models is what we need. And probably this organization should be able to define them at a universal level. And there are benchmarks. Peri-procedural mortality, 1% in this is what we need to achieve. We can look at the FAME data, 1-year follow-up data. These are data that we must achieve with coronary surgery. This is an excellent trial, excellent outcomes, and this is the benchmark for every center. We cannot do less than that. And to our shame, this is an old slide showing some recommendations that were made in 2018. And actually have in a guideline. And if you look at your center, are you doing this? And I have to say, even for my center, not always. This is just a summary of all the recommendations that are in there. And up to 225, we have not managed to make that as international standard for coronary surgery. It's not that we find anything new here. We just need to do what we already agreed on many years ago. And by 2030, I would hope that we do this, all of us, and that would already make CABG better. Now, the future of surgery, of course, and I would add these two to Michael Mack, is not only ablation over excision and so on, it's data and AI driven. And we have to think about the patient journey, which will change dramatically as we speak. So patients will have different access to information. They will come as informed individuals. They have apps which probably already do a self-assessment, and they can have a digital hospital, so everything available to them without even talking to us. And then, of course, maybe also do self-diagnostics. The big question is if they need a center to do diagnostics, and this diagnostic center will also help them to find a decision. And there's already avatars that can explain to the patient what they have. And patients trust these avatars. There's studies about this. They are professional, trustworthy, they use your language, they are empathic, they can repeat it 10 times, yes, your LAD, what is it, why do you need a bypass graft? Or they can tell you need PCI. And that will be the big question, who's programming these avatars, and on what basis will AI decide to make what recommendation? And this is a big threat for surgery, because the majority of papers, the majority of organizations work for PCI. And that's how AI will learn. And that's how it ultimately will make their decisions. And soon, this will be the major source of information for patients. They won't come to your office. They will talk to an avatar which will explain something to them. Hopefully talk also about surgery. The virtual heart team, knowledge-based decision-making, all this integrated information that we get from phenotype, from patient charts, from imaging, from guidelines, all that has to be integrated. And obviously that will be an AI-assisted heart team, because only that can ultimately integrate all this information. And it will look like this. So large language models play a large role in deciding if we will recommend a patient PCI or CABG. Of course, as John alluded to, imaging will be completely analyzed and with the help of AI. And also this information will be integrated in algorithms that ultimately will guide the heart team for a decision of PCI or CABG. And already the ESC, the big European Society of Cardiology, has launched their chatbot in 25. And so now patients or cardiologists or we as surgeons, you can ask a question and then the ESC chatbot will tell you what to do. And guess what it will tell you, right? Actually, if you ask Open Evidence today, which is also an AI, trustworthy AI platform, you have a patient with triple vessel disease, should it get PCI or CABG? You can type it in today. It will recommend CABG, actually. So Open Evidence, which is built on the information from major journals, sticks to the rules. But I'm not sure about this one. Well, anyways, don't quote me on this. So, but it's something that we have to deal with. We need to do this. So, precision medicine. We treat many patients the same, or all of the patients. They come in, triple vessel disease, get 3 bypass grafts. So the disease, and then everyone gets the same. But we are not the same. Everyone is different, so we need different therapies. And of course, one patient is doing well on OMT, one patient is doing good on PCI, one patient will do good with CABG, but we don't know who they are. So what we need on top of the risk assessment tools that we have, syntax score and so on, we need other biomarkers. And of course, what we haven't touched on today is the omics parade. So we can know much more about our patients if we look at the whole genome. And whole genome sequencing right now is very cheap and it takes only a day to do. And I think that if we do this, we will come to other conclusions. So let's say we have a patient, we have an electronic health record, we have information on the genetics, we have the bioimaging, and we have large language models. Ultimately, the combination of all this will define what treatment option is best for this patient. And if you go one step further, and that's something that we currently look at, and this is a little bit crazy maybe, but we look for other healthcare spaces. So we have a collaboration with BMW in this case, and equip this car with a whole lot of sensors and also radar sensors for all kinds of measurements, so that that car already knows in what physical shape you are when you approach it, and it can tell you what your physical condition is. It does a gait analysis. It can, by sitting down, tell you how fit you are. And once you're in the car, your EKG, everything else will measure it, sensor, I mean, without a device attached to you. And that information ultimately may end like this, you know, because it's a longitudinal health space. You do that every day. This car will drive you immediately to a center of excellence, obviously, not any center, maybe the cooperating partner Charité in this case, where you can get your arterial grafts and an appointment is already made, and the car, because you do ERACs, already knows that 4 days after it can bring you back home. So in summary, what I think we need to discuss in this community, really serious about CABG being a subspecialty. We need to make use of state-of-the-art technology. We need to fulfill the patient demand for less trauma while maintaining the prognostic benefits. So that's something that we really have to take serious. And if we manage all this, we may stop the undeserved decline of CABG altogether. Thank you very much.
Yeah, thank you, Volkmar. I think you all know now what I meant when I introduced him. So I think everything has been said, though, and that's why we will stop there and not go into a panel discussion. And if there are no burning questions,